welcome to my channel. So today we are going to be talking about adrenal insufficiency. So objectives are going to cover the anatomy, the physiology, the types, clinical presentation, investigations, and as well as management. Then we are going to go through adrenal crisis. We will go through the definition, symptoms, triggers, and management. Okay. Then this is the anatomy of the adrenal gland. So we have the right and the left adrenal gland, which sits on top of the surface of the kidney, and we have the adrenal gland itself as the adrenal cortex and the adrenal medulla. So the adrenal cortex as the connective tissue capsule, it has the zona glomerulosa, it has the zona fasciculata, it also has the zona reticularis. These are the parts of the adrenal cortex. Then this is the adrenal medulla. Okay. Then, so what do they do? So the zona glomerulosa produces mineralocorticoids. Okay. Then mineralocorticoids example you can give is aldosterone. Then the zona fasciculata produces glucocorticoids, and an example you can give for glucocorticoid is cortisol. Okay. Then lastly, the zona reticularis produces androgen precursors. Example DHEA, which is dihydroepiandrosterone, and also it also produces some androstenedione, but it mostly produces the DHEA androgen. Okay. Then in terms of physiology, we start with the glucocorticoids. So the glucocorticoids are so named because they have an important influence on glucose metabolism, and increased hydrocortisone secretion results in elevated blood glucose levels. Then however, the glucocorticoids have major effects on the metabolism of almost all organs of the body. Then glucocorticoids are secreted from the adrenal cortex in response to the release of adrenocorticotropin hormone. This is ACTH from the anterior lobe of the pituitary gland. Then the system represents an example of a negative feedback. So the presence of glucocorticoids in the blood inhibits the release of corticotropin releasing factor, or CRF, from the hypothalamus, and also inhibits ACTH secretion from the pituitary. So this is the negative feedback. So when there is a presence of glucocorticoids in the blood, there won't be the release of CRF or CRH, which is corticotropin releasing factor or corticotropin releasing hormone. Okay. So when there is no corticotropin releasing factor from the hypothalamus, it also inhibits the secretion of ACTH from the pituitary gland, since the corticotropin releasing factor is the one which also promotes the secretion of ACTH. So when there is no CRF, there won't be any ACTH. So the resultant decrease in ACTH secretion causes diminished release of glucocorticoids from the adrenal cortex. Then glucocorticoids in the form of corticosteroids are administered frequently to inhibit the inflammatory response to tissue injury and suppress allergic manifestations. So their side effects include the development of diabetes mellitus, osteoporosis, peptic ulcers, increased protein breakdown resulting in muscle wasting, and poor wound healing, and redistribution of body fat. Then large amounts of exogenously administered glucocorticoids in the blood inhibits the release of ACTH and endogenous glucocorticoids. Then because of this, the adrenal cortex can atrophy if exogenous glucocorticoid administration is discontinued suddenly. So in short, adrenal insufficiency results because of the inability of the atrophied cortex to respond adequately. Okay, so but we'll go further into the types of adrenal insufficiency. Okay, then what about mineralocorticoids? What do they do? Okay, so mineralocorticoids exert their major effects on electrolytes metabolism. So they act principally on the renal tubular and gastrointestinal epithelium to cause increased sodium ion absorption in exchange for excretion of potassium and or hydrogen ions. Okay, so this is a very important thing to remember, especially if we begin our studies. So that's the function of the, and we gave an example of mineralocorticoid. We said aldosterone, so meaning they all act on the renal tuber and the gastrointestinal epithelium to cause increased sodium ion absorption, in exchange for excretion of potassium or hydrogen ions. Okay, then ACTH only minimally influences aldosterone secretion. Okay, it is primarily secreted in response to the presence of angiotensin 2 in the bloodstream. Then angiotensin 2 is a substance that elevates the blood pressure by constricting arteries. It is a potent vasoconstrictor. Okay, then its concentration is increased when renin is released from the kidney in response to decreased perfusion pressure. So the resultant increased aldosterone levels promote sodium reabsorption by the kidney and the gastrointestinal tract, which tends to restore blood pressure to normal. The release of aldosterone is also increased by hyperkalemia. Okay, so these are some of the things you have to know, and that aldosterone is the primary hormone for the long-term regulation of sodium balance. Okay, then finally let's talk about the androgens. So the adrenal sex hormones. So androgens, these are the major type, the third major type of steroid hormones produced by the adrenal cortex. They exert similar effect to those of the male sex hormones. Okay, so the DHEA, the androstenedione. So that's what you have to remember. Then the adrenal glands may also secrete small amounts of some estrogens or female sex hormones as well. Then ACTH controls the secretion of adrenal androgens. Okay, so that's the thing you have to know. Then when secreted in normal amounts, the adrenal androgens probably have little effect, but when secreted in excess, in certain inborn enzyme deficiencies, masculinization may result, and this is known as androgenital syndrome. So that's the thing you have to know about the anatomy and the physiology. Then in terms of types, we have the primary one. So the primary, this is where the damage is on the adrenal cortex itself. So that's why we call it primary, because there is a direct adrenal injury, direct adrenal cortex injury. Okay. Then when we say secondary, we are talking about the anterior pituitary gland, or the anterior pituitary gland. So that's secondary, meaning it is away from the adrenal glands themselves. But depending on your literature as we are using, there is also a tertiary adrenal insufficiency. But remember, if you don't find tertiary adrenal insufficiency, meaning, or even if we say tertiary or secondary, all of them, as long as they are occurring away or outside the adrenal glands themselves, or in a condition where there is no direct lung injury, direct adrenal injury, adrenal cortex injury, then they all can be considered secondary, just depending on the classification or the literature that you are using. Okay, but in this literature specifically, we are going to say secondary and tertiary. What we mean by secondary is because secondary we are talking about the anterior pituitary gland, then tertiary we are talking about the hypothalamus. Okay, since we said under secondary, that is where the ACTH comes from. Okay, then if the ACTH is only responsible for directly acting on the adrenal glands to secrete the sex hormones, the steroid hormones. Then in the hypothalamus, that is where the CRIF comes about. So, but the CRIF doesn't necessarily directly act on the adrenal glands. It first goes and promotes the secretion of ACTH. Then ACTH go to the adrenal glands to promote secretion of steroid hormones. So that's why we say tertiary. So that's why we say tertiary, then secondary. Okay. So let's start with primary first. So primary adrenal insufficiency. This is when adrenal glands do not produce enough steroid hormones, particularly cortisol and aldosterone. Then causes of primary adrenal insufficiency, of course, we have condition where we can have direct cortex injury in conditions such as autoimmune adrenalitis. So you have to check for adrenal autoimmune antibodies as well as 21 hydroxylase antibodies. Okay. Then we have the most common worldwide, which is adrenal infection. So this is the most common cause worldwide. Such as example, the most common example I can give is TB. Okay, which causes direct cortex injury. Then, but for in developed countries like the US, the most common cause is the autoimmune adrenalitis. Okay, that's the autoimmune cause. Then you can also have another example, which is adrenal hemorrhage. So, for instance, when someone has Otterhaus Friderichsen syndrome, which occurs as a result of bleeding into the adrenal glands due to the meningococcemia that occurs when the bacteria Neisseria meningitidis invades the bloodstream. Okay. Then we have also adrenal metastasis, which is a less common cause, which can be caused by lung cancer, breast cancer, but you actually need more than 90% bilateral metastasis for it to actually occur. Okay, then what I'm sure you have heard of Addison's disease. So what is Addison's disease? So Addison's disease refers to the specific condition where the adrenal glands have been damaged, resulting in a reduction on the secretion of cortisol and aldosterone. But this is also called primary adrenal insufficiency, since there is also direct cortex injury. So primary adrenal insufficiency is also called Addison's disease. Okay. Just that when we say Addison's disease, meaning we are talking about more of a chronic case. Okay. Then we can now go to secondary causes. So secondary adrenal insufficiency. So is a result of inadequate androcorticotropin hormone ACTH stimulating the adrenal glands, resulting in low cortisol release. So ACTH is produced by and secreted by the anterior pituitary gland. Okay, that's our secondary adrenal insufficiency. So this is a result of loss or damage to the pituitary gland, which usually leads to reduced ACTH, reduced DHEA, but there will be normal levels of aldosterone levels, since since ACTH doesn't necessarily have it has minimally effect on the aldosterone release, as we talked of in the physiology. Okay. Then in terms of the causes of secondary adrenal insufficiency, we have hypopituitarism. Such hypopituitarism causes such as in Sheehan's syndrome, which is a condition that occurs postpartum when a woman breathes a lot. So when someone breathes a lot, the pituitary gland is the one which is responsible for almost a lot of processes in the pregnant woman or the female body in the pregnant state. Now after they bleed out, they tend to go into hypopituitarism. Okay. Then the other thing which can cause hypopituitarism can have pituitary apoplexia. So pituitary apoplexia, an example we can give is when someone has a pituitary adenoma, which ruptures into the tumor bed and causes infarction, then necrosis of the pituitary, which leads to reduced ACTH release. Okay. Then another factor could be or is pituitary macroadenoma, which is a tumor that is more than 10 millimeters, which causes direct compression of the pituitary gland, again which reduces the production of ACTH. Hence, you have to look for the mass effect signs such as bitemporal hemorrhagia. So these are some of the causes of hypopituitarism or condition that is affecting the pituitary glands. Okay. Then also another thing which can cause secondary adrenal insufficiency, we can have surgery to remove the pituitary tumor as well as radiotherapy. Okay. Then that's the end of the secondary causes. Let's now discuss about the tertiary adrenal insufficiency. So tertiary adrenal insufficiency is as a result of inadequate corticotropin releasing hormone or CRH or CRF. So it is an inadequate CRF release from the hypothalamus. Then CRH is also known as corticotropin releasing factor, which is a peptide hormone that activates the synthesis and the release of ACTH from the pituitary gland. So that's why we are calling it tertiary, because it's not necessarily direct acting on the adrenal glands, but just stimulating on the anterior pituitary gland to produce ACTH. And ACTH is one which will go to act on the adrenal glands. Okay, then causes of tertiary adrenal insufficiency. We have the most common, which is hypothalamus suppression, which occurs in chronic steroid uses, such as in prednisolone and prednisone, used for more than 3 weeks, and someone just stops taking suddenly. So these prednisolone and prednisone are exogenous cortisol, which leads to increased cortisol levels, and of course there will be a reduction of CRH, which of course will which will lead to reduction of or reduced ACTH release. Again, it will tend to lead to adrenal atrophy. But when steroids are discontinued, there will be a reduction in cortisol. But because when the exogenous steroids are suddenly withdrawn, the hypothalamus does not necessarily wake up fast enough, and the endogenous steroids are not adequately produced. Hence, long-term steroids use should be tempered down slowly to allow time for the adrenal axis to regain normal function. So that's the thing. Then that's the end of the classification: primary, tertiary, primary, secondary, and tertiary. So if you meet a literature which classify them into two, primary and secondary, you don't be dismayed. Just know that whatever we talked about in tertiary, then you just have to put it in secondary, because they have added both the hypothalamus and the anterior pituitary gland together as secondary causes. So there's no need to fret. Okay. Then in terms of clinical features, so clinical features can be characterized by muscle weakness, anorexia, gastrointestinal symptoms, can have fatigue, emaciation, a dark pigmentation of the skin, knuckles, knees, elbow, and mucous membranes. It can also lead to hypotension, and apart from hypotension, it can also lead to low blood glucose levels, low serum sodium levels, and high potassium levels, and of course reduced libido. Then mental status changes such as depression, emotional ability, apathy, and confusion are present in 60 to 80% of the patients. Then in severe cases, the disturbance of sodium and potassium metabolism may be marked by depletion of sodium and water and severe or chronic hypertension, severe chronic dehydration. Then with the disease progression and acute hypotension, the patient may develop Addisonian crisis, which is characterized by cyanosis and the classic signs of circulatory shock. So there will be pallor, apprehension, rapid and weak pulse, rapid respirations, and the low blood pressure. Then in addition, the patient may complain of headache, nausea, abdominal pain, and diarrhea to show signs of shows signs of confusion, restlessness. Then even slight exertion, exposure to cold, acute infections, or decrease in salt intake may also lead to circulatory collapse, a shock, and death if untreated. So then the stress of surgery or dehydration resulting from preparation for a diagnostic test or surgery may precipitate Addisonian or hypotensive crisis. So these are the signs and symptoms. So, but to do a recap on the things we have talked about, I just removed most of the signs so that at least you know the signs you can look for. So signs, you can have hypoglycemia. So hypoglycemia comes about due to reduced cortisol. You know that reduced cortisol will lead to reduced gluconeogenesis and reduced glycogenolysis. Okay. Then you can also have bronze hyperpigmentation of the skin. You all know that this usually happens in primary. It usually occurs in primary AI, which is primary adrenal insufficiency, where there is a lot of ACTH, which is stimulating the adrenal glands. Now, when there is a lot of ACTH also ends up stimulating the melanocytes to produce melanin due to the increased levels of the alpha melanin stimulating hormone. Okay, so it will lead to a bronze hyperpigmentation of the skin. Okay, then there will also be hypotension, so particularly orthostatic hypotension, also known as postural hypotension. Hypotension. Okay, then investigations, we can have acidosis. So how do you know that someone has why do they have acidosis? So in primary AI, which is primary adrenal insufficiency, there will be a reduced, so it's supposed to be reduced, there will be reduced aldosterone, which will lead to reduced sodium and increased potassium and increased increased hydrogen ions, which will lead to renal tubular acidosis type 4. Okay, so someone will have a metabolic a non-anion gap metabolic acidosis. Okay, so there will be metabolic acidosis. So in short, how do you test someone has acidosis? There are a lot of ways. Okay, you can do your blood gases, you can do any test that can show you that someone has acidosis. Okay, so remember, aldosterone is one which was causing sodium reabsorption. It was causing potassium excretion. It was also causing hydrogen ions excretion as well. But when it is reduced, it will do the opposite. There will be reduced sodium, increased potassium, and increased hydrogen ions. Okay, then even the test, that's how if you do electrolytes, your serum sodium is going to be low. There will be hyponatremia. If you do your potassium, your serum potassium, there will be hyperkalemia. It is high potassium. Then if you check your ACTH levels, so ACTH levels, you have to know that in primary adrenal insufficiency, the ACTH levels is high as the pituitary is trying very hard to stimulate the adrenal glands without any feedback in the absence of cortisol. Remember the negative feedback that we were talking about and the positive feedback. Then in secondary adrenal insufficiency, the ACTH level is low because the pituitary gland is not producing adequate ACTH to stimulate the adrenal glands. Then in tertiary, meaning the ACTH levels will also be low since the pituitary glands are not necessarily being stimulated to produce ACTH. Then the other test you can do is the adrenal autoantibodies. So adrenal autoantibodies, you can check for the adrenal cortex antibodies as well as you check for the 21 hydroxylase antibodies. Okay, that's what you check for. Then you can also do a CT or MRI adrenal glands if suspecting an adrenal hemorrhage, tumor, or other structural pathology. Okay, the investigations again can do which is the investigation of choice, which is ACTH stimulation test. The ACTH stimulation test. So it is also known as the Synacthen test. So the test involves giving Synacthen, which is a synthetic ACTH. So Synacthen is just another name for a synthetic ACTH. So there are two types of ACTH stimulation tests. We have the short and long Synacthen test. So we have the short Synacthen test and the long Synacthen test. So the long Synacthen test is rarely used anymore due to available tests for measuring ACTH levels, and this can indicate the underlying cause. Okay, so meaning we only use the short Synacthen test since there is availability of ACTH measuring the ACTH levels themselves. So there is no need for someone to use the long Synacthen test, so it is rarely used. Okay, but the short one is still the test of choice for adrenal insufficiency. It is performed during the morning when the adrenal glands are not necessarily overworked or mostly fresh. Then the synthetic ACTH will stimulate healthy adrenal glands to produce cortisol, and the cortisol levels should at least double. Hence, the blood cortisol is measured at baseline. Then you also measure them at 30 seconds. Then, so it's supposed to be and. So we measure them at baseline, 30 minutes and 60 minutes after administration of synthetic ACTH. So when you measure them at those intervals, if you get a failure of cortisol to rise at least less than double the baseline, it's going to indicate a primary adrenal insufficiency. Okay, so meaning if it doesn't do that, then it is a secondary. Okay, then replacement of it may be then replacement of steroids is the mainstay treatment and is titrated to signs, symptoms, and electrolytes. Then hydrocortisone is the replacement steroid of choice. It is a glucocorticoid hormone and is used to replace cortisol. Then there's also another one, it is fludrocortisone, which is a mineralocorticoid hormone, and it is used to replace aldosterone if aldosterone is also insufficient. But it is also advised to identify the cause of the adrenal insufficiency. Okay, then complications. So complications of adrenal insufficiency, you can have an adrenal crisis, that's an endocrine complication. Then in the CVS, you can have shock. Then in the renal system, you can have a renal tubular acidosis type 4, which is a non-anion gap metabolic acidosis. Then you can have also one of the metabolic complications is a profound hypoglycemia due to reduced cortisol, like we talked about, that reduced cortisol reduces gluconeogenesis, reduces glycogenolysis. Okay. Then you can also have neurological, such as a profound encephalopathy due to reduced cortisol as well. Okay, then now let's talk about the adrenal crisis. So the definition for adrenal crisis is that this is a potentially life-threatening disorder which arises from an acute deficiency of adrenal hormone, cortisol, which is a glucocorticoid. Then adrenal crisis should not be confused with chronic stable adrenal insufficiency, such as Addison's disease or primary adrenal insufficiency. Then how does it present? So presentation of adrenal crisis that there will be reduced consciousness, hypotension, hypoglycemia, hyponatremia, hypokalemia, and the triggers. So the triggers for what can trigger adrenal crisis can have infection. So infections such as sepsis and Waterhouse-Friderichsen syndrome. Okay. Then we can also have trauma and as well as post-operation. Then you can also have a sudden discontinuation of steroids after long-term use. Can also trigger adrenal crisis. Then you can also have an acute illness in someone with an established Addison disease. So meaning when someone has Addison disease, then they tend to have an infection, they have an acute illness. Thus, the stress can trigger adrenal crisis. Then they wake up in adrenal crisis is just the same thing. So you do a serum chemistry, which will be abnormal, and the abnormalities that are present in as many as 56% of the patients. So they will be hyponatremia, which is common, although not diagnostic. There will be hyperkalemia, metabolic acidosis, hypoglycemia also may be present. However, the absence of laboratory abnormalities does not exclude the diagnosis of adrenal crisis. The chest radiography can be used to assess for tuberculosis. Like we said, we investigate the cause: histoplasmosis, malignant disease, sarcoid, and lymphoma. Then abdominal computed tomography or CT scanning can be used to visualize the adrenal glands for hemorrhages, atrophy, infiltrative disorders, and metastatic disease. Then also have to know that adrenal hemorrhage appears as hyperdense bilaterally enlarged adrenal glands. Then in primary adrenocortical failure, histological evidence of infection, infiltrative disease, or another condition may be demonstrated. Then secondary adrenocortical insufficiency may cause atrophy of the adrenals, or no histological evidence at all. So this is the wake up in adrenal crisis, which is of course just the same thing we did, but with of course finding out exactly why someone is having the crisis. Okay. The management of course is through administration of glucocorticoids in physiologic or stress doses, which is the only definitive therapy. So examples, but you have to follow your hospital guidelines. Examples you can give with there will be parenteral steroid replacement with hydrocortisone, which is 100 milligrams start, then 100 milligrams every 6 hours. Or others find that they give 200 start, then they taper to 100. Okay, the others will give the 100 start, then they taper to 50. That's how different the guidelines are. Okay, then you also have to correct hypoglycemia. So you have to correct hypotension by IV fluid resuscitation. You also have to do careful monitoring of electrolytes and fluid balance. Then if the patient is very unwell, you have to take them to ICU for his monitoring as well. Okay, so that you even reverse the trigger. Then the other thing I wanted to share was on dexamethasone. So you have to know that dexamethasone does not interfere with the serum cortisol assay, and thus may be the initial drug of choice. However, because dexamethasone has little mineralocorticoid activity, fluid and electrolyte replacement are essential. Then a thorough search for a precipitating cause of adrenal crisis and the administration of empiric antibiotics can also be indicated. Then reversal of coagulopathy should be attempted with fresh frozen plasma, and pressors such as dopamine or norepinephrine may be necessary to combat the hypotension. That's what I wanted to share, and thank you for watching. If you haven't subscribed, please subscribe and hit the bell notification, and see you on the next video. And thanks for the subscriptions.